Welcome back to Rohrich Knows Podcast. I'm Dr. Rod Rohrich. I'm a board-certified plastic surgeon in Dallas, Texas. So today we're going to talk about scars, prevention, management of both how wounds heal, but what happens when they go awry. So I'm honored to have with me Dr. Janine Hopkins, who's a board-certified dermatologist here in Dallas, Texas, and in Monroe, Louisiana. And she's an innovative dermatologist that really is an expert in scar management therapy. So welcome, Janine.
Thank you. Thank you. I appreciate you having me on your podcast. It's such an honor.
Good.
And exciting topic I'm very passionate about.
Yep.
Been doing a lot of deep dives into medical literature regarding wounds and scars and how we can better prevent and treat them.
So tell us, obviously, every time, as a plastic surgeon, I always tell my patients, we're gonna, we'll hide your scar, we'll make it almost so that it's hard to see. But no one can ever, once you make an incision on someone, you'll always have it. I always tell them, it's up to God and wound healing, and you can't make scars disappear. Now you can make them less visible. So, and then 85% of the time, scars heal well, especially in normal patients. But when they go awry, they turn into, abnormal scars. Sometimes they're called hypertrophic scars, which are scars that are within the boundaries of your incision. And then if they really go wild, they become keloids. And then they go outside that boundary, and we'll show you examples of that, and I'm sure Janine's going to talk about that. So Janine, tell me about how you manage your normal patient that you do, let's say, Mohs surgery on or closures on, and then tell me what happens when it doesn't look good and it becomes a hypertrophic or a keloid scar.
Well, I've actually spent quite a lot of time lately reading some articles, just figure out where did it all start with this, healing ointment that would just say put some Vaseline on it and put a Band-Aid on it, because that's literally a lot of what we tell patients. I create a lot of wounds when I remove atypical nevi or malignant lesions. And so if you go back into the deep medical literature, the original wound healing was let it dry out, scab over to be fine. Well, then we know that's not such a good idea. There were studies that showed a moist wound healed better than a dry wound, hence the ointment. And then it became antibiotic ointments until we realized we were actually causing bacterial resistance. We were, using them indiscriminately on clean wounds that didn't need Neosporin. And then a lot of people became allergic to some of those active ingredients. So then it just sort of became, well, just put something on it like an Aquaphor, Vaseline, or CeraVe. And so I, like probably 99% of other doctors who are treating and taking care of open new wounds or surgical wounds like you are, just, put the ointment on it. But it doesn't really make a lot of sense when we've got more innovation coming our way. So at this point, for new wounds, I'm really doing more of what's referred to as hydrocolloid bandages. In dermatology, we've used those for quite a long time on, say, an open wound in a diabetic patient or a traumatic wound from a burn or injury, where we'd want to put a sheet over it that was impregnated with wound healing ingredients that was also a second skin and a protectant.
Right.
And data is definitely showing that those wounds heal better. Yeah. And so the new bandage technology is that we can now buy these boxes at the drugstore, you can get CVS or Walgreens or wherever, and you'll see on the label it's going to say hydrocolloid bandage.
Just helps you moisturize your skin. Yeah.
Yeah, and you put them on, and they actually perform like a second skin.
Right.
And studies on that show that you just apply it to the wound, you leave them on for 7 days without taking them off. They're waterproof, which is great for my patients who won't stay out of the swimming pool, despite the fact that I used to tell them don't go swimming with an open wound. But at least with these hydrocolloid bandages, we're getting a good seal, we're getting waterproof, we're getting a good wound healing environment under that bandage. So that's been a new shift just in my dermatology practices on what we're doing for these new wounds.
Yep.
And the idea is twofold. We heal better and we heal with less scar.
Yep. Yeah, no, I agree.
Yeah,
I agree. And I think, in plastic surgery, I would echo everything you said. I think the big thing is most wounds, unless they're compromised or under tension, they heal fine, if obviously staying out of the sun, wearing sunscreen, is if they're moisturized. And you're right, don't use antibiotic ointment if it's healed, and if it's healing well, I usually will know in 3 to 4 weeks. And just a moisturizing cream, a hyaluronic acid cream, most moisturizers have hyaluronic acid in it. And then only at 4 to 6 weeks, if the scar becomes raised or hypertrophic or keloid, is when you need to act. So tell us about when you act on that type of scar, when it's raised in red versus hypertrophic.
Well, one other little new twist also on just the wound healing stage itself, and this kind of might take us down another rabbit hole, but there's actually a medical grade LED blue light. The one I have is from Italy. It's called EMOLED, and it's just new to the U.S., but it's been in Italy, and they've been using it in Europe in a lot of studies looking at enhancing wound healing and preventing scarring from either burn scars, surgical scars, traumatic scars, and even the chronic ulcerated scars in some of our seniors and diabetics that have poor circulation. So I can talk a lot about that, but new acute scars, even in your OR, the data is going to show that if we would expose the wounded tissue to about 120 seconds of this medical grade blue wavelength of light, it's going to help orchestrate quicker, better wound healing.
Yep.
And if you have a patient with a propensity for keloid scarring, or someone that has a wound in a very cosmetically sensitive area, such as the face, the protocol would also be that you not only do the light therapy in the OR or in the office at the day of the procedure, but you have them come back in the 1 week, 2 week, 4 week to continue helping enhance. So that's a protocol to actually help reduce the chance of someone developing an unsightly keloid or hypertrophic scar.
Yeah.
So better healing on the front end, so we're not having to take care of problems once they've already happened, like 6 months later, they come back and it is a keloid scar.
No, I agree.
Yeah.
In fact, countries and Asian countries do that a lot. And I'm actually working with a company called Elixir MD, and we're doing 2 protocols now for facelifts and pre-op facelifts and pre-op rhinoplasties. And we're doing 20 minutes of blue light therapy before we get to the operating room. And then in the operating room, we do yellow light therapy. And again, that enhances wound healing, decreases bruising, increases cellular stimulation.
So I'm a huge fan of light therapy. I mean, it's photobiostimulation. It's an entire science that segued off of, we do a lot of laser treatments in dermatology. And so, now we've got, well over a decade worth of scientific research on using light therapy. Right. Now, the problem is it's also become a mainstream,
fad.
Sephora, Amazon, buy the little mask, which, okay, it's cool, but the problem is you've got to know that this device is literally putting out the correct wavelength that will penetrate, and not just penetrate, but absorb.
Right.
And so my advice to my patients all day long who are like, should I buy one of these LED masks? And I'm a huge fan of light therapy, but for sure you want to make sure that whatever device you're about to spend money on has FDA clearance. Yeah. Because if they don't have that labeling on their website, on their box, then you do not know what you're getting other than just some visible light that's got some blinking going on. Right. So consumers beware when it comes to things being sold on whatever website.
Yeah, no, I agree. I agree. And it's not just the color light, it's actually their total, and not even the wavelength so much as the frequency and the joules, the total joules, because, a lot of these red light therapy masks that they sell on Amazon, I mean, they may just be red light. I mean, because if you don't get the total joules, you're not really getting the therapy you want. And then, there's red, infrared, it depends on the wavelength, and it's obviously a different topic, but kind of know before you go. So I think that's the light therapy is good for preventative. So now let's get into, you've got the wound, you've got a hypertrophic or a red scar. How do you treat that? How do you treat that when and in patients of color, and really any patient? I usually see it at 4 to 6 weeks, and then personally, as a plastic surgeon, I began them on silicone gel for 24/7.
Oh, for sure. Yeah, no, a huge fan of
Yep.
silicone gel sheeting.
Yep.
There's some different pharmacies we work with that actually even impregnate certain medications into that. Like we need a little steroid into the silicone pads, or we needed an anti-redness ingredient. There's one that even has the HA, vitamin C in the pad. So yeah, so silicone pads are excellent to put on. And I'm a big fan too of the day they come in for suture removal, to start doing the pads preventatively.
Sure.
But when the patients come in and they've already developed the, let's talk about hypertrophic, and then we'll go keloid if we've got time. I don't want to run out of time, but hypertrophic, as you said, for our audience, is the scar. The scar still is contained within the incision line or the wound line, but it's become thick, it's become raised, it's become hard. And so what we've got is too much collagen scar tissue production. So the 3 phases of wound healing, some of these patients who have a genetic predisposition, that's one of the risk factors for keloids and for scarring is your genetic predisposition. So we know some people have a higher risk, but also the patient's underlying metabolic health. People who have maybe diabetes might have more problems with healing, and sometimes it's location. The sternal chest is prone to keloid. Shoulders, over the shoulder blades tend to keloid. For some reason, earlobes, even from getting things like just simple piercings, are prone to keloid. So anatomical locations and genetic predisposition can lead to keloid.
So how do you treat the hypertrophic scar? So how do you treat it?
Hypertrophic scar, yeah. In my practice, when they come in with hypertrophic scarring, we're going to incorporate usually some intralesional injections with a Keloid steroid. And so I'll, based on the thickness, I'll decide on the dose or concentration. I'll actually inject the steroid into the scar tissue. And usually we'll put some numbing cream on first, and if patients are a little anxious and a little laughing gas, so they're not, having too much discomfort, but it is an injection of the medication. Then in my practices, we often will incorporate microneedling. It's a great way to break up old scar tissue. It seems kind of counterintuitive to make wounding when you just had a scar that didn't heal well. But after that, we'll incorporate either platelet-rich plasma, or we talked on one of our podcasts about exosomes is a great time to incorporate them into this wound healing process, and then the light therapy. And so I'm usually doing a combination of those treatments.
So you're doing microneedling, exosomes, and then light therapy.
Platelet-derived growth factors.
And you put silicone feeding.
We'll finish that with a little blue light therapy. And then we'll put some silicone pads, and their responsibility is to, I'll prescribe them a scar gel. There's several to choose from. And there's one even often covered by insurance called Salicin. And at home, they'll do the scar gel and the scar pads. And I'll see them back on like a 3 to 4 week cycle. As we're starting to get improvement, we'll even go a little bit longer, like 6 weeks. And then I often use my laser. I have a laser called Photona. It allows me to choose between fractionated resurfacing or fully ablative. So another technique, if I've got a really thick hypertrophic scar, is that we'll actually take the erbium laser settings and use it on a fully ablative and just take it down. Now, of course, we know, again, we're creating wounding in response to that procedure. But again, using these other modalities, we're going to make sure this time when that wound heals, we're in control, and we're going to make sure it heals properly. So that would be the most common management in my practice for hypertrophic scarring. And I had a patient in today. She'd had a C-section that became raised and hypertrophic, and so she was, I believe, 4th treatment today, and it was significantly better. Matter of fact, the ends of it were smooth and flat, and we just had still a little bit right in the middle. And today, and I modified, like the settings we did today and the treatment protocol today was a little different than what we started with 4 months ago, because the scar had changed, right? We'd gotten smoother, flatter. So I did not inject her with steroid today because it didn't need it anymore. And we just did laser. We just did some post-treatment exosomes and some blue light.
So, now keloid. Tell us how you manage a keloid scar. This is an abnormal scar outside the border, abnormal healing. It's a problem.
Well, it's super complicated. If you look at the medical literature, the chance of recurrence of a keloid from a surgical excision is it's well over 90%. So the problem is you come in, and I've got some before and after pictures I think we'll be able to show. You see these large keloids on an earlobe. We can cut them out, but we know that it's just going to be a matter of time before here it goes again. And so over the years, traditionally, we would, debulk it either with a shave or an excision to take it back down and close it up. And then we would have those patients coming in for injections. I mean, I almost want them to sign a contract with me that they promise they'll come back for their follow-ups every month so we can keep taking care of this.
Yeah, I abandoned that a long time ago, too.
Yeah. But now, here's the two new innovations. The EMOLED blue light out of Italy, I've got several papers and articles that have been published where day one is you take down the scar with the surgical procedure, either excision or with the shave removal. You expose it to the blue light at the time of the procedure, and they come in once a week until the wound is completely healed for light therapy. And then they come in on a monthly basis, and we do that for 3 to 6 months. And the recurrence rate is extremely low compared to the other options, which we used to do was just, silicone pads and steroid injections monthly and hope it didn't come back. But the most definitive treatment for keloid scars is image-guided superficial radiation therapy. That goes back to another one of our podcasts where we discuss using that for treating skin cancer, basal cell and squamous cell carcinoma with a 99.3% cure rate. But there's also FDA clearance and data on using radiation therapy to cure keloids. Now, the way that works is they'll come in on day one, the surgery day, the procedure day one, and we'll surgically debulk or excise the keloid. And then after we get hemostasis, control of the bleeding, they'll then go into my radiation therapy room and we'll treat over that area with about 45 seconds of x-ray therapy. And then they'll come back on day two, about 48 hours later, and then do their third treatment at the end of the week, and that's it. We do 3 SRT treatments, and the cure rate on these keloids is well above 95% using that modality.
Yep, I agree. That's what I do, a couple of times a year. I actually, if it's a patient that has a hypertrophic scar or keloid rather, mainly it's usually from a tummy tuck or maybe even from a breast surgery. You just cut it out, and that same day you go for superficial radiation, like you said.
Yeah, it's great. And they feel well.
Yeah, the old way of doing it was cutting it out, injecting with steroids. Don't do that. Just bypass it because the success rate is in the high 90s. If you do it the way you just said, and it just makes life so much easier, because the definition of insanity is doing the same thing over and over again and expecting a different result. And that's what we used to do in surgery, and with a hyper, especially a keloid, because I personally don't like injecting steroids even in a hypertrophic scar, because then you can get widening. But I like the light therapy. I like the ablative surgery. I mean, the ablative laser. Those are all good. But definitely, and
the main thing is just control the whole healing process, because the problem with the hypertrophic scars is that in the healing cycle, there's just excessive collagen production. And so we need to be in control. And that's one thing about the light therapy is it changes the signaling pathways.
Right. Exactly.
So we really know. I mean, it's amazing to me that, a wavelength of light that's blue can literally alter signaling pathway in our skin, but it happens, and it's cool science. So we love it.
Yeah. I just need to see some more good studies to show that it'll supersede excision with superficial radiation. I mean, I don't know.
Well, and at this point, I think SRT is definitively the best treatment.
I totally agree. I think that's the standard of care versus blue light. I mean, I don't know. Maybe the data from Italy and other countries will see that.
It's coming. And I think it hopefully that'll pan out to be, the cure rates, and probably in the 90% if we can achieve that. Maybe the protocols need to be tweaked and modified. But I think combination therapy in dermatology, especially, I feel like we always achieve the best results when we're combining different things to get the optimal outcome. So, but I do think if someone currently has a history of keloid with, larger keloids, the debulking it surgically and doing the 3 doses of X-ray therapy afterwards is just a game changer. And it's given my patients some remarkable
I agree.
Results and great quality of life. Only issues we have right now is it doesn't have a pediatric indication, which is kind of frustrating from some of the patients who are under age 18. Again, I think we have to talk over and educate over, kind of the negative connotation that some people have on radiation therapy. This is X-ray therapy. This is super dose, low dose. It's super safe.
I agree.
So yeah, and then as far as that goes, those are only some of the limitations. Is just maybe cost of procedure if insurance company doesn't cover it. But I've even had some luck getting insurance coverage for those treatments because of the debilitating keloid risk for patients.
Wow, wow, amazing. All you ever wanted to know about scar management, normal to abnormal to keloids and hypertrophic scars. Wise words from an amazing, innovative dermatologist, Dr. Janine Hopkins. So thank you very much. Give us your thoughts, give us your comments. Stay tuned to Rohrich Knows podcast. And till next time, stay safe and stay educated.